Hello, everyone. I'm Kerim Munir, joining from Boston, Massachusetts. Thank you for the invitation to the Symposium on Multidimensional and Multidisciplinary Approaches to Intellectual Developmental Disorders and Autism Spectrum Disorders. It's a pleasure to be with you. I have no commercial conflicts of interest, just research and research training funding from sponsored programs. The learning objectives for this presentation is to discuss the issues related to the confluence of autism spectrum disorder and intellectual disability, also called intellectual developmental disorder, in terms of three areas: epidemiology, diagnostic criteria, and genetics, and in terms of also the variation in ASD psychiatric comorbidity with co-occurrence of IDD. I would look forward to some questions in the future from you, and my email is here listed in this slide. Epidemiology. This national survey data regarding prevalence rates of developmental disabilities in children ages 3 to 17 years diagnosed by selected developmental disabilities, including autism, intellectual disability, other developmental delays, and developmental disability, shows an increase in other developmental delays and developmental disabilities in general, despite efforts for prevention, and also, of course, the increase in the autism spectrum disorder with a sustained level in intellectual disability. The trends in the prevalence of intellectual disability in ASD, cerebral palsy, hearing loss, and vision impairment is depicted in this slide. As you can see, a really profound increase in the level of autism spectrum disorder compared to the other disabilities, again, as reflected in this slide. This is the slide from the US Department of Education data involving number of children, students registered in the individualized educational plans as part of the Disabilities Education Act, which is a mandate for public education in the United States. And as you can see, the intellectual disability rates are decreasing and autism is increasing, and some have called this diagnostic substitution. At the same time, it's very important to note also that other health impairments, including deaf, blindness, developmental delays, and multiple disabilities and orthopedic impairments have increased in children as well. So this slide from the Swedish population study shows that there is no such thing as a socio-economic advantage in autism. And in fact, in autism with intellectual disability, there's a socioeconomic disadvantage, as depicted on this highlighted area of this slide. The diagnostic criteria, this is another second important topic on my presentation. And I would like to emphasize the fact that there is tremendous discordance still in the diagnosis of intellectual developmental disabilities or intellectual developmental disorders between the DSM-5 and the proposed ICD-11. The DSM-5 has in fact accepted the World Health Organization ICD-11 content model, in which I participated, chaired by Dr. Luis Salvador Carula, of which Dr. Marco Bertelli was also a very prominent member. And as a paradigm shift was proposed when the naming of intellectual developmental disorder as a neurodevelopmental condition, onset during a developmental period, with no age of onset and specified, and the IQ scores were essentially abandoned for severity measures and replaced by adaptive functioning. And as DSM-5 emphasized, because it's adaptive functioning that determines need of intervention. And the DSM-5 and American Association of Intellectual Developmental Disorders have had some debate as to the maintenance of the disability construct by the AIDD, but moreover, in terms of the question of whether the intellectual impairment and adaptive functioning should be dependent on one another, which DSM-5 proposed, as opposed to not, which AIDD has emphasized. But they also introduced the idea that of a developmental age of onset expanding into age 22 in the new proposal in 2021. On the other hand, as you see on the top of the slide, there is really very minimal discordance in the AST, with the exception of the sensory, minor sensory items between DSM-5 and ICD-11. So the WHO ICD-11 model essentially maintains the severity distinction based on intellectual scores and stratification into mild, moderate, severe, and profound, using standard deviations as noted in this table, but is essentially maintaining intellectual disability and what they have actually acknowledged as being a neurodevelopmental disorder and labeled as intellectual disorder, intellectual development, but essentially fitting it under the bell curve. This situation, of course, comes with the provision that appropriately normed and standardized tests are to be available, and diagnosis of disorders of intellectual development requires reliance on clinical judgment, which I think is understandable. So getting into the distinctions between autism spectrum disorder and intellectual developmental disorder, the DSM-5 AST criterion E is very important in terms of the disturbances are not better explained by IDD or global developmental delay, which is to say that social communication domain in autism should be below that expected for general developmental level, as explained by co-occurrence of intellectual developmental disorder. To what extent the attention is paid to criterion E, and also in terms of the point I make here in item number 3, that the criterion B, adaptive function, which is a social domain out of the 3 domains, conceptual, social, and practical, focusing on the social domain, you would see some overlaps with some of the symptoms of autism, and therefore in relatively young children with global developmental delays, you might see a pull into ASD diagnosis rather than maintenance of early diagnosis of intellectual developmental disorder, which again is understandable, and that might explain some of the diagnostic substitutional issues that might be going on. Finally, the genetics and variation of ASD psychiatric comorbidity with intellectual disability, I would again emphasize that ASD wins in this area. Funding favors ASD research. ASD research without IDD have been historically overrepresented, although that's changing. And early intensive interventions de-emphasize IDD, seen as greater stigmatizing condition, immutable condition, and so on. Which is historically the case based on, the stigma that has been ongoing in this population for such a long time. But there was also issues, for example, that nonverbal children with ASD in low resource settings in low income countries might be assigned diagnosis of intellectual developmental disorder, even though their nonverbal intellectual functioning is high. So the bias can work the other way as well. And the final points is that in terms of research, the ADOS and the ADI, which are these standard gold standards for measuring autism, have not been validated in persons with severe to profound intellectual disability, and also that ADOS and ADI availability is limited in low income and low resource settings, particularly in low income countries. This slide shows the genetic crossroads. Essentially, the summary for this slide is that the genetic abnormalities associated with ASD is significantly higher with comorbid intellectual developmental disorders, as you can see on the top row here. And also, genes associated with ASD are often the same genes also associated with IDD. So, and in fact, significant portion of children with ASD without any of the problems that are listed in terms of the top labels here have no genetic abnormality, at least at this point in time. However, I would say that in individuals with autism spectrum disorder in the higher functioning borderline intellectual range of cognitive functioning, common variation is the sine qua non, whereas in terms of the lower intellectual functioning levels are associated with de novo loss of function mutations, significantly correlated with lower IQ scores in ASD. Higher IQ scores also correlate positively with family history of psychiatric disorders, as depicted in this slide, with also correlated with the psychiatric hospitalization rates in males and females, with family history of bipolar disorder and schizophrenia for males and females, respectively, going up with the full-scale IQ scores going up in this report. The Stockholm Youth Cohort Population Study, a nested sibling comparison study that has been shown in this JAMA report, essentially shows that ASD without IDD was associated with depression by young adulthood. And this was actually substantiated through the Swedish public records that capture clinically diagnosed cases only. And these were about 4,000 diagnosed with ASD, of which 2,900 without intellectual disability and 1146 with intellectual disability. And you can see a higher elevated rate of depression in the ASD group without intellectual disability. Synapses to behavior, causes of IDD and ASD are highly heterogeneous. Understanding and mitigating the developmental, neurobiological, environmental influences is paramount, and identified mutations converge onto similar or related etiological pathways, and clarifications of the lines of confluence is essentially likely to pay scientific dividends. Studies of sociability, cognitive ability distinction, for example, and also to emphasize early intervention services ought to be initiated at the time of first concern for both ASD and global developmental delay. And that, in fact, the research and service bias differentially favors ASD, and parents seek out ASD diagnosis to secure better services. And therefore, it's very important that we need to pay attention to reduce disparities in services exacerbated by social disadvantage, and also parental awareness that needs to be increased, particularly in low resource and low income country settings. Early service provision ought to therefore emphasize needs over classification. Finally, current view is that the IDD is a comorbid independent condition and linked as a specifier in the classification in DSM-5, and unrelated somehow in etiology and causality with ASD itself. Now, given the heterogeneous perspectives that I have emphasized here, one cannot make this argument completely. Recent advances in developmental neuroscience highlight also the importance of early exposure to social experiences for cognitive development itself, as supporting an alternative view that intellectual developmental disorders in ASD might emerge because of severe social communication deficits on the experience-dependent mechanisms underlying neurocognitive development itself. So according to this view, children with greater ASD severity at an initial assessment are therefore more likely to present with poorer cognitive outcomes at a later assessment, irrespective of initial cognitive level. So ASD symptom severity contributes to the extent to which the environmental input required to support typical brain development can be processed, and the risk of developing IDD increases as the severity of ASD social communicative impairments increase. So intellectual disability, intellectual developmental disorders, speech impairment are important measures of predictors of outcome in ASD, but the ASD severity itself, irrespective of initial cognitive level, needs to be also taken into consideration in the measures of outcome, in terms particularly of the children's ability to learn, and also in terms of the severe social communication deficits leading to these limitations in the experience-dependent mechanisms underlying neurocognitive development. Thank you very much, and have a great meeting.